Hello everyone, good evening. This is Dr. Sullivan back with you for another I Care for Your Brain Wednesday night lecture. My desire is to come to you once a week to bring you education and empowerment involving different brain health issues. Tonight we are going to be talking about emotional symptoms following stroke. This is a very, very important topic because we cannot forget that the results of a stroke are always psychological in nature, in addition to, of course, being biological and social. What neuropsychologists like me do is that we specialize in what we call the biopsychosocial approach. And that means that we care about all three of those things. We care about what happens to the integrity of the actual brain, but we also care very much about people's adjustment, their mood, their emotions, their behavior, and of course, the effect of their injury on how they are in the world, the effect that other people have in response to them. So what we're going to do tonight is try to approach this topic from that perspective. Prior to me opening up my private practice here in North Carolina in Pinehurst, I was the inpatient stroke neuropsychologist at the UNC Stroke Center. So I feel like I have a good sense of stroke, not only through my education and the patients that I see now, but for the time I was at UNC, I was really focused on stroke. And I feel like I learned a lot about people's adjustment to it and the different treatments that are out there. So what we're going to focus on tonight is talking about how stroke affects people uniquely in an emotional and in a psychological sense. We never want to forget, like I said at the beginning, that a stroke is not simply something that leaves people with physical or cognitive symptoms. A stroke is almost always a traumatizing experience, both of course physically and psychologically. So we always have to make sure that we're trying to investigate and help with the things that might not be readily apparent to the primary care physician, the neurologist, the rehab doctor. We want to kind of look underneath the hood, so to speak, and make sure that we understand what is going on. Following a stroke, there are all sorts of so-called normal reactions that people can have, and I'm going to take you through, I think it's the top 8, top 9, to go over those. But what I really want to focus on tonight is something that is so important, that if we ignore, the person is guaranteed to not make as good of a recovery, even from a motor perspective, a cognitive perspective, and of course an emotional perspective, and that is post-stroke depression. This is a very real phenomenon that happens for a variety of reasons, and why it's so important is because it absolutely inhibits optimal rehabilitation and optimal recovery. People will not get as better as they could if the depression that happens after stroke is not properly assessed and treated. And this is really where neuropsychology comes in. So I thought this would be a great topic for us to talk about tonight. We are going to end, as we always do, with what are some state-of-the-art, evidence-based recommendations that you can walk away with tonight, either applying to yourself or a loved one, that will really make a difference. So if we take a step back and get started with our topic, let's talk about the 2 types of strokes that people can have. Now, you might hear strokes called by a variety of different names. Some people call them CVAs. This is cerebrovascular accident. And there's really 2 primary types of stroke. There is an ischemic stroke and there is a hemorrhagic stroke. We can just think of them very simply as not enough blood or too much blood in the brain. Ischemic strokes are related to blockages that happen in blood vessels, and these account for the majority of strokes. So this is anywhere from about 60 to 80%. Hemorrhagic strokes, in contrast, are when we have a blood vessel in the brain that erupts and we have too much blood in the brain. This accounts for about 20 to 40% of all the strokes that happen. Blood in the brain is a very caustic situation. The brain does not like blood in there whatsoever. So we have a unique set of stressful things that happen in the brain after we have a hemorrhagic stroke. the problems we have in ischemic stroke is that where that blockage happens, everywhere beyond it that was once fueled by the blood and oxygen that came through that blood vessel is going to die. Depending on where these strokes happen in the brain dictates the types of symptoms that we have and the severity of the symptoms. There are other factors that also make a difference too, and this is really related to the integrity of the rest of the brain. A stroke is always a focal injury. So what this means is that we have the whole rest of the brain that was in its same state of health after the stroke that it was before the stroke. So of course, the younger you are, the more healthy you are, the smaller the stroke that you had, the quicker you get to medical care. All of these things make a difference for long-term outcome. Right after a stroke, people who have survived have a variety of what we would interpret as normal reactions. Now, some of these can cause the person a lot of distress, but we never want to stereotype how people should react after a brain injury. And in fact, if you look at the research, there's actually 2 or 3 different responses that are relatively common that don't involve distress or being upset in any way. And I'm going to talk to you about those in a minute. So we think of these as kind of the 8 normal responses. So the first one is what we would consider to be guilt and self-blame. And this often comes from people who have been warned that they have stroke risk factors, and for a variety of reasons, they were not able to make enough lifestyle behavior changes to make a significant impact on those risks, and the person goes on to have a stroke. Now, of course, people can also be extremely compliant with their recommendations to avoid a stroke, and they may go on to have a stroke no matter how perfect they were at following the recommendations. But this is a common reaction where people say, oh, darn it, why didn't I take those pills like I was supposed to? Or why did I forget them when I went on vacation? Or why didn't I get on that treadmill? Why didn't I stop smoking? There's this kind of feeling like you had control over this happening, and if only you would have done something about it, maybe this wouldn't have happened. Some people who have survived a stroke talk to us about immediately feeling guilty about the level of care that they are requiring, even when they're in the hospital. I've heard this from people who say, you know, I bet these nurses have someone else that really needs their help. Or, you know, my poor wife has been in here every night for the last 2 weeks. I really am feeling very, very guilty that she has to spend her time here. So that's the first thing when I think about a common reaction. The next one is anger. Feeling like you're angry at maybe a doctor who didn't warn you enough about the consequences of not doing something. Angry at God. How could this happen to me? Angry at, a family member for maybe it was hereditary and someone else in your family had a stroke. Can just be a very normal reaction, particularly depending on your type of personality. We're generally what we call internalizers or externalizers. So we can either have problems that when we get stressed, we kind of make those feelings very internal and we can become very anxious, very depressed. Some of us are just externalizers and we become very, very frustrated and we channel that energy outward. So it really depends on the type of person that you've always been, how it's going to go in the post-stroke adjustment phase. Of course, many people have a very normal response of feeling afraid, feeling like this might happen to me again. The definition of a traumatic event is that it comes out of nowhere and that it's life-threatening. This is the criteria that we use as psychologists to determine if someone meets criteria for post-traumatic stress disorder. That was something that we always thought of as happening to veterans. We then broadened the category of who could meet that criteria to people that were survivors of sexual assault and rape. But really since the 90s, we've also been including people who have medical crises. The first group that we thought of was people with breast cancer, people who got a out of the blue cancer diagnosis. Well, we now know that this can also happen in stroke. So anything that happens to us that threatens us, particularly if it threatens our very life, we always respond with a feeling of fear and kind of being on high alert. Oh my gosh, is this going to happen to me again? Of course, we come face to face with our own mortality when we are talking about stroke. So nothing like having the illusion of safety and eternal life popped to make you feel a little bit fearful. The other thing is that we know when people have their mobility limited in any way, including with a stroke, that there's a lot of fear that comes up around falling. So this can get in the way because people are then not as likely to want to get up and do their physical therapy, do their occupational therapy, get their rehab exercises in, because they're afraid that they're now unsteady on their feet and maybe they're going to have a fall. Remember, I was telling you there's actually two emotions that are generally positive. Many people feel a lot of gratitude once they become cognizant again after the stroke. They feel, thank God this wasn't worse. This was a wake-up call. We can be recipients of incredible amounts of support and love and friendship and concern after something like a stroke. It can really be impressive how your community and your family and your friends show up for you. Cards and food and hugs. It can be really, really, really heartwarming to see how many people come out. For many people, they have increased spirituality after a stroke. It's kind of like a wake-up call. You know, what am I really doing with my life? Where am I finding my meaning? How am I giving back? And probably that has something to do with the what if, right? What if I wouldn't have survived this? What am I really going to be facing when I meet my maker? It's certainly considered to be a healthy coping strategy when we think with a spiritual mindset, and it's really been proven to be associated with better health outcomes also in stroke. We know that churches can be a wonderful source of support for people. So many times when, someone's pastor comes to visit them at the church, that means a lot, and it can really bring people back into the fold of a spiritual community. The next two that we're going to wrap up with in terms of these normal reactions are shame and grief. There can be a lot of shame, self-consciousness, worry about judgment, how other people might perceive you following a stroke, and that can involve anywhere from crying when you've never been a crier, not remembering your words, having problems with bladder control, your ability to get back to walking, to driving, to holding a cup, to working. I mean, there's all sorts of ways that we get our identity from our doing. You hear people say all the time, try not to be a human doing, be a human being. Well, we're not very good at that, especially in our American culture. And so when you can't do those things anymore, and you can't be independent, which is kind of held up as the end-all be-all of being a functioning person, that really, really, really takes a toll. And many people can feel a tremendous amount of shame, sadness about what they can no longer do. And the last one, of course, is grief, which is the most normal response to any type of loss. There is no right way to grieve. Nobody can give you instructions on what you're supposed to do. And in fact, my opinion is that the vast majority of information out there on grief is actually horrible. It's a lot of avoidance, stay busy, don't cry. When I work with people in therapy situations, the major goal that we have is something called intentional grief, which is to really allow yourself to feel safe and comfortable within your emotions. You have a right to feel however it is that you feel. Nobody can take that away from you. It's very important, and I'll talk about this when I get to treatment, to make sure you have someone in your life, whether it's a friend, family, clergy, or a professional, that simply allows you to have your emotions about what is going on with you. So I want to talk a little bit now about depression, specifically this post-stroke depression. So depression is very different for every person, and the truth is that I think we have a lot of stereotypes about depression. But there's this cartoon that I have that I show people when I do talks about depression, and it's got a little do not disturb sign on it, and it says, there are days when I wish I could just wear one of these around my neck. And I think that actually is a very good metaphor for how a lot of people experience experience depression. It really is more than just feeling sad every now and then. Clinical depression is after 2 weeks feeling on more days than not that you are having a really hard time, to the point that it affects your everyday functioning. So what that hard time means is different to many people, like I said, and it can either go with too little or too much, but there are some general categories. So your mood, of course, is a big one, feeling sad, guilt, not feeling interested in things that you used to like, and really a big common one is just not getting any joy, pleasure, interest from things that really used to touch you and make you feel happy. A lot of people who are depressed talk about feeling numb inside, almost like they can't feel anything at all. You see people have ups and downs with appetite, eating too much, eating too little, sleeping too much, sleeping too little. People can have a lot of difficulty being around other people, feeling kind of agitated, feeling restless. But the way I want us to think about depression is that it's really a downward spiral. So once you feel depressed, then you stop doing things that might actually make you feel better, like being with other people, being social, eating well, sleeping well. And then of course what happens is all of those things actually make us feel more depressed and less likely to do those things. So many times it actually takes almost like an intervention, someone who cares about us, to step in and to be really direct in a loving and respectful way and tell us that they are concerned about us. And that is a big part of what I'm going to get to when I talk about, well, what can we do about this stuff? So I want to just talk to you about rates of depression and stroke because it's pretty impressive. So we have some data where we look at the hospital phase, the rehab phase, and then 6 months after stroke. So what the research tells us is that while people are actually in the hospital, that there's a 23 to 41% likelihood that someone will develop depression. That's actually pretty high. During the rehab, this actually goes up to anywhere to 72% of people post-stroke. In different studies, of course, give us different data, meet criteria for post-stroke depression. It goes down a little bit when we look at outpatients. So this means once they're done with rehab, and we're looking at about 6 months post-rehab, anywhere from 26 to 42%. This is actually very likely, though, an underreport, and this is very important. It is probably underreported because people are not getting proper assessments. People are simply not asking the right questions, and the people themselves may not be communicating the symptoms either because of cognitive symptoms, so difficulty with speech, finding their words, difficulty organizing their thoughts inside their head to communicate them, or all of those other things I just talked to you about, feeling ashamed, feeling like I don't want to bring this up. This is yet another thing that I'm not doing well at, right? The other thing with depression, and this really might be how it gets us, is there's this feeling of why bother? Why even bring it up? What difference is it going to make anyway? It also doesn't help that we've got these lickety-split doctor's appointments these days where you're in and you're out. One of the things that I cherish most about having my own practice is that I get to set the parameters on how I take care of patients. And in fact, this is why I really left the academic medical world, is because I did not feel that I could practice under those constraints. It is my opinion that you cannot get the full scoop on what's going on with people in a 15-minute appointment. It's just not possible. There's just too many things to talk about, and you have to appreciate context. This is why neuropsychologists are such awesome people, is that we care about the big picture. We care about the history. We care about what's changed for this person and what it means. There are some risk factors that set people up to be more likely to have depression post-stroke, and generally these are the younger people who have strokes. Anyone who has been depressed previously in their lifetime is much more likely to develop depression after a stroke. people who have fewer close friends, people who have low formal education seem to be more prone. And the severity of the stroke, there's kind of like a little sweet spot in there. So people who have very, very, very severe strokes are reported to have very low levels of depression. But again, can we really trust the statistic? Because maybe they literally cannot speak anymore. And so we're using, sad and happy and angry faces and asking people to point. That's not exactly a comprehensive assessment of mood. But there is also something to be said about symptoms of loss of insight and awareness after someone has had a severe brain injury of any kind. So the truth is, we also may have people that if they were more cognizant and they were more aware, they may very well be depressed, but they are limited in their cognitive abilities because of the stroke, and they just don't perceive it that way. And sometimes we look at that actually as maybe sometimes a blessing. We're pleased on some level that the person actually doesn't appreciate all that they've lost. Symptoms of depression after a stroke seem to peak at about 3 to 6 months. And there is debate about the cause, but we're almost positive that it's multifactorial. And this is where we get back to that biopsychosocial model, right? So we know that there is, of course, brain damage that happens in a stroke. And so this is the bio part, right? This depends on the physical location of the stroke and the chemical changes that happen after the person's stroke. The psycho part of biopsychosocial, of course, refers to the person's previous coping skills, their way of processing stress, their social supports, the integrity of their mental health before they had the stroke. The social part refers to that loss of independence, people's reaction to the person. The experience of being disabled in the world is very underappreciated. And until you have been there before, I don't think that you can really, really presume to know what it's like. And that is why I always try to seek out information from people who have actually lived it and ask them what it's like. Because even though I've studied this in books and I have helped and care for many, many people with brain injury, I have not had a stroke, and I cannot say how it would feel to be in the world and have a hand that doesn't work well, or to be off balance, or to have my words come out slurry, to have a face that was paralyzed on one side. This is a very difficult way. People can be very, very cruel. And so what we think is that post-stroke depression is these three things coming together. What is critical, though, is the chemical change. And so what we know is that strokes disrupt a lot of different things in the brain, and the brain is a chemical and an electrical system simultaneously. We are really ruled by things called neurotransmitters that have both positive and negative action to them. And when one type of neurotransmitter gets disrupted, it's very much like the hormone system in that everything kind of gets out of whack. So one of the things that we know about mood, of course, is that it's very heavily dependent on things like serotonin and dopamine, norepinephrine, variety of neurotransmitters working together. So when we have disruption, it's very likely that there's going to be effects on mood. People can talk about also having too many emotions after a stroke, and this can actually be another cause of depression. Men, in my experience, can be very embarrassed because they're crying and they were never a crier before. People have something called emotional lability after a stroke, which is where their emotions are like all over the place. So laughing 1 minute, crying 1 minute, sad about this 1 minute, grateful the next minute. And this can, of course, make you feel like you're on a roller coaster, and this can be very distressing to people. The costs of untreated depression following a stroke are huge, and this is really why I wanted to focus on this topic tonight. When people are depressed after a stroke and it is not treated properly, their outcomes are not as good. It is a barrier towards optimal recovery. And if people don't know this, they can't make changes for themselves or a loved one, and they're not going to have the same type of outcome. And the whole idea of what we're doing here is how can we improve on brain health challenges? So Depression is associated in and of itself with cognitive symptoms, trouble making decisions, trouble focusing, trouble with memory. So now we have maybe some cognitive symptoms from a stroke, and on top of this, we now have cognitive problems from depression. Okay, so now we've got two reasons to have a problem. We also know that when we're depressed, what did I say before? We stop doing the things that are actually helpful to us. So we're not as likely to be social. Being social is a very cognitively stimulating and rich experience that really, really helps the brain have to figure out how to do things different after a stroke. Remember, a stroke is a focal injury. Even people who are of very advanced age who've had previous strokes, mini strokes, they're always going to have another part of the brain that can work better than the part that's been injured in a stroke, right? So we have to make sure that people post-stroke are learning and being exposed to experiences that basically make the brain have to reroute, get to the same endpoint, but have to bypass the damage that's been happening, that has happened to them because of the stroke. And this happens with stimulation, and being with people is absolutely proven to be one of the most stimulating things that we can do. So we also know that people who have had depression and when it's not treated, what we know is that they do not go to their physical therapy appointments as much. They tend to have ongoing problems with sleep. They don't take their medications as they're supposed to. They are much more likely to have chronic pain. Depression is also a physical experience for many people. And so for all these reasons, we can get into a lot of trouble when we don't treat depression. So here's the great news about what we're talking about. This is a treatable problem, okay? There are 3 ways that we work on depression after a stroke, and this is counseling, medication, and what I like to call self-care. The first thing we're going to talk about is counseling. Then we're going to talk about one of maybe the most exciting studies that I've ever heard about, called the FLAME trials, that happened in 2011. I'm still talking about it 6 years later. That taught us so much about antidepressants, taught us so much about what to do for our loved ones that have had strokes. So I'm going to tell you about that in a few seconds. Many people don't really understand what counseling is. Okay, counseling is simply giving yourself the gift of time each week to actually focus on what's going on with you with a trained professional who can be your guide. They are not there to solve your problems. They are not there to tell you what to do. They are simply there as an informed, respectful person to have a back and forth with, to give you tools to think through your problems yourself, okay? I'm a big proponent of neuropsychologists for people who have had strokes, because we're gonna come to you with the education about what has actually happened during a stroke. One of the things that I can get really worked up about is when people who don't understand the brain do counseling with people who have had any kind of a brain injury. So this can go from Parkinson's disease and the anxiety that comes along with it, to traumatic brain injury, to stroke. And the idea is that you have to have reasonable expectations for what people can do in their recovery. If you tell someone with Parkinson's disease, for example, just don't worry about it. Why are you letting these things bother you? You can't stop thinking about it. That's making your anxiety worse. Okay, they don't understand these subtle changes that can happen in the frontal lobes with Parkinson's that can literally make it hard to get unstuck from topics that bother you. You need to have someone that is skilled in cognitive functioning to really work with you to give you the best, most realistic tools for helping yourself. Support groups can also fill this role very, very well. You've got people who have walked this path before. I always say you don't want to reinvent the wheel after any kind of brain injury. You need to learn from people who've come before you. And you can also really benefit from the support of other people. Sometimes our families are not the most supportive, and we need to have other people there to be able to be gentle with us and understanding, and support groups can be really, really good in this way. What therapy really does, in addition to everything I said, is it really increases our capacity to cope. We all have coping skills, and they're both positive and negative. A good therapist is going to gently push you in the direction away from your negative and help you increase your repertoire of positive coping skills. They can help you manage when big emotions come up. They can really help you regulate and not get swept away in the emotions. We can also understand the price that you're paying for untreated mood symptoms and increase motivation to go further and further into treatment. We're really good at helping people establish personal goals, helping them get back into the world, reestablishing a sense of identity, and of course, working on acceptance about what has truly changed and what are the things that you can control with intervention on your own. I want to talk to you now about medications for post-stroke depression, because this is why you have to share this video. Of course, if you know people who have had a stroke and we're worried that maybe there's some depression, this is huge. You have to talk to them about this. So there's something called the FLAME study, and this came out in 2011, and this is one of those like highbrow, really good quality studies where it's randomized, it's placebo controlled, it's double blind, there was multiple centers. It's what we call a phase 2 trial. So that means we can have some nice, strong feelings of faith that this was actually a well-conducted study and that the conclusions that they came to are genuine. So what they did is they followed 113 people in the hospital who had recently had a stroke, and they either gave them 20 milligrams of Prozac or a placebo, a sugar pill. And they put them all through physical therapy, right? So everybody got physical therapy. One group got Prozac, one group did not. They made sure none of these people had post-stroke depression, okay? This is critical. These were people that had motor symptoms only, so they had difficulty using one of their hands. They made sure that they took the Prozac anywhere from 5 to 10 days following when they had the stroke, and they gave it to them for 3 months. And what they did after is monitored how much improvement that they had had in their independence and in their ability to use their hand. And what they found after 3 months was that the group that had the Prozac increased 10 more points than the placebo group in getting the use of their hand back. And 26% of the folks on Prozac had achieved what we call functional independence, so the ability to live on their own and manage all their activities of daily living, as opposed to only 9% in the placebo group. This is pretty impressive stuff. Now, we do need more data, of course, but what we can conclude from this is that in addition to intensive physical therapy and occupational therapy and speech therapy, which are critical, it really looks like getting an antidepressant, specifically Prozac, into the brains of people who have had a stroke not only probably improves mood, but actually improves motor function. So this has been replicated in a few different studies, and at this point we've had about 4,000 people, their data be published in research studies, and it's really been proven across different, what we call selective serotonin reuptake inhibitors. So this goes for different types of antidepressants. What's so cool about this study is it really changed the way that we think about how antidepressants work. Before this, we used to think a lot exclusively about serotonin, that depression was related to a chemical imbalance. And what this study strongly suggests is that, and we also know this from some imaging studies, some MRI, is that there are neuroprotective mechanisms that also happen with the use of antidepressants. So that's a very fancy word. What do I mean by that? What I mean by that is we've got these brain cells, right? And we've got a nucleus in the middle, and how the brain really works is that there's these little connectors that jet out from the core of the cell called dendrites, little kind of like branches, little fingers. And what the Prozac did, we think, is increase the amount amount of dendrites, the amount of connectors that could then go on to communicate with other brain cells. So it would not be accurate to say that it's growing new brain cells, but it would be accurate to say that it's growing new aspects, new dendrites, new connectors on brain cells that are then going to help the overall recovery of the brain. So this is huge, and I want you to use this data to your advantage, because this is what I do in my sessions with people. I kind of use it in two different ways. One is I always make sure that people are aware of this data who don't have depression, just so they can make more informed choices about what they want to do. But if I have someone in front of me who I think has post-stroke depression and they are hesitant to want to take an antidepressant, man, I start whipping out this data, and this can really, really change people's perspective. And for whatever reason, this is just my experience, for some reason this data can get men on board with taking a medication. Women, I feel like, again, maybe a stereotype, are more open when I start talking about medications, but there's some kind of guys who are just like, nope, it's not a problem, not taking it. When I start talking about the fact that you might not get the use of your arm back as much if you don't take this medication, I'm in. It feels like I make a lot of ground in a very short amount of time. Now, this is an off-label use. It is not FDA approved for post-stroke motor recovery, but ethically, physicians are perfectly able to prescribe these medications when they feel like it is justified by scientific evidence, and we feel really good about the fact that we have that. Now, of course, we always want to know about risks with medication, so I looked into that last night to prepare for our time together today, and there is thought to be a very, very, very small risk of a lack of blood clotting that can happen with Prozac. And so basically, one of the things Prozac can do is make platelets in the blood, which are really there to stop bleeding by kind of clumping together and clotting. It can make that a less efficient process. So in a meta-analysis of over 500,000 people who did not have a stroke but who took Prozac, the risk of having bleeding in the brain because the blood wasn't clotting was about 1%, which is really, really pretty small. I always make the decisions that I suggest to my patients by running it through a couple different filters in my brain. Of course, the first one is, what would I do if, this was my mother in front of me? But I always think, what would I want to do for myself? And the truth is, if I have a stroke, I will absolutely be taking Prozac immediately. It'll be the first thing that I communicate. So where is this data now? Why aren't you hearing more about it? Well, the way science works is we need more and more data before we can do things like get this FDA approval. So right now there are 3 large multi-study randomized controlled trials that are going on. They're called Focus, Affinity, and Effects. What they're looking at is actually giving it to people for 6 months to see if maybe we can get a more longer or a more strong, robust effect. And we're thinking that these are going to be done in about 2018, and here we are. So I think we're going to be hearing about that more and more. I have a prediction that it will be a standard of care for post-stroke rehabilitation in the very near future, that this is just a part of rehab, and it's a way to, the way I kind of think about recovery from all brain injuries, and again, this is Alzheimer's, Parkinson's, stroke, traumatic brain injury, is you want to create an environment in the brain that is most conducive to healing. So this is where really good sleep comes in, good nutrition, and I think that we can also look at these antidepressants in that same way. It's basically giving the brain as many tools as you possibly can for it to naturally recover on its own. Let's conclude by talking about some other things that you can do for yourself or a loved one. I think the very first thing is the assessment part, and that's kind of the neuropsychologist in me, right? Until you know your map, until you know what it is you're dealing with, it's kind of hard to jump to the treatment or the what do I do. So notice the signs in yourself, notice the signs in somebody that you care about, right? Learn more about depression. The big thing is, if you think that emotionally, psychologically, socially, there has been a change in the person, that is when I would want you to get curious and get more interested. It's amazing how avoidant we are as a society about emotions. Just asking the person directly, how have you been feeling since you had your stroke? My experience for people with so many brain health issues is that people actually don't ask that much. They either presume or they avoid. And I'm here to tell you that people who have brain health issues want to talk to you about what they're going through. They want to be heard. They want to be validated, just like anybody else would for any other issue. One of the things that I was saying to quite a few people during the holidays, people ask me all the time, well, what can I buy for my sister who has dementia? Or, you know, my cousin had a stroke. What kind of products are out there? And I often tell people, it sounds kind of corny, but the truth is your presence is genuinely the present, right? Just simply being there. You don't have to solve the problem. You just have to be curious and genuinely caring. Okay. The other thing is that you have to realize that you can't really cure the person of their depression. The best thing that you can do is advocate for them to talk to their doctor or get their permission to go to their doctor yourself and express your concern. You can have them watch this video. I'm a big believer in knowledge is power, and until people understand the rationale behind medical recommendations, you know, who wants to take another pill? But if you can take the time to explain to people exactly what is going on inside their brain, of course people want to get better. You know, that's a no-brainer. I really want you, if you have had a stroke, to please go to see a neuropsychologist. I know this can sound like a broken record each week, but I really chose this profession because I believe wholeheartedly in the tools that we offer you to get better and to understand your situation better. And I think, again, a standard of care for anyone who has been in the hospital for a stroke should absolutely be an assessment with a neuropsychologist. So many times people either don't get referred, they just get sent back to primary care. Many people do get to go to a neurologist, and maybe they then send you on to the neuropsychologist. But part of why I do this and why I do talks in my community is to help people advocate for their own best care. And I really feel that a neuropsychologist can improve the outcome for you or somebody that you care about after a stroke. Thank you guys so much for listening. Next week, we're actually going to do a blast from the past because I'm going to be out in the community doing a talk. So I actually look back at all my old talks, and I think that there's some really good information about sleep apnea and why people must learn to love that CPAP machine. It is the most disliked medical device, but I'm going to talk to you about the importance of why you have to use it and how to try to be more compliant, as they say. I so appreciate being with you guys every week. I hope that you're finding this informative and empowering, and please help me in trying to spread the word. I just want as many people to know this important information as possible. If you're a part of any type of online stroke support group, please share it. I think that so many people are out there suffering needlessly, and maybe this lecture would be a small step in helping somebody to recover better. Thank you guys so much, and take awesome care. Bye.